bundle, and as you can see, it's again the same thing. Establish intravenous access, obtain weight, measure lactate, draw blood culture, hypotensive, give a 30 ml per kilogram IVF bolus. And then if it's very septic, severe shock, then you're going to make sure the MAP is greater than 65 millimeter per mercury. And then you're going to do reassessment. So it's just the same thing. So this is known as sepsis survival bundle. Okay. So this was a campaign released in 2021, and if I'm not correct, if I'm not wrong. So this is known as Surviving Sepsis Campaign. So the main aim was to do this: give antibiotic as soon as possible, make sure BP is maintained. That's all. So nothing more up in the Surviving Sepsis Campaign. And since everyone was speaking about scores regarding the QSOFA score and Muse score, so there are two scores. One is QSOFA, the other one is Muse. Muse is too complex. You have a calculator online, so you just type in the details, you're going to get it. QSOFA is something that is asked. QSOFA is basically, it's going to say if you have to, if there is evidence of organ dysfunction or not. So this doesn't clinically change a lot. You're just going to evaluate more. So if there is an altered mental status of less than 15, tachypnea of 22, greater than 22, or hypotension less than 100 systolic, then you're going to say there is a higher chance for organ dysfunction. You're going to evaluate for it. Nothing more than that regarding QSOFA score. There's a Muse score. It's a very complex scoring system. So yeah, it's okay if you don't know this. Learn QSOFA for exams. So yeah, we'll move on to the appendicitis, which is today's topic. And that was just for some people who asked yesterday. So I think Shreya was the one who asked. I'm not sure exactly, but yeah. Apart from that, today's topic is appendicitis, so don't get confused. So appendicitis, as you can see, we have to first know about the anatomy. So what is the position of appendix? Where is it located? Or rather, where is it derived from? You can put the answer in the chat box. It's a derivative of foregut, hindgut, midgut. Which gut is it? So appendix is derived from dash A, B, C. No, which is the derivative, like embryology, back to basics. So appendix is derived from midgut, yes. So appendix is derived from midgut, so that is the correct answer. So it is going to be situated in the base of cecum. It has its own momentum known as mesoappendix, and through the mesoappendix, the appendicular artery, which is a terminal artery, it's a terminal artery, so it's going to supply it. The appendicular artery is in turn a branch of ileocecal artery. The ileocecal artery is a branch of dash artery. Ileocecal artery is a branch of dash artery. Is a branch of, okay, is a branch of even more, go back, SMA, yeah. That's what we are expecting, SMA. Superior mesenteric artery, which is in turn a branch of abdominal aorta. So that is the blood supply of appendix. Remember, the one thing is appendicular artery is going to be a terminal artery. Just remember that. Okay. No, this is a direct picture from Teach Me Clinical Anatomy. I think it's ileocecal. It's not ileocolic. It's ileocecal artery only. So ileocecal artery, appendicular artery, and then you move on. Ileocolic is okay. So the position of appendix is variable. See, there are multiple positions for appendix. Okay, each position is going to be variable, and based on positions, you're going to have symptoms and signs. Based on ileum, pre-ileal, post-ileal, then you have your subileal, pelvic, subcecal, paracecal. All of this is present, but the most important thing is those that are present like this, which is the most difficult to find. Remember that. So this is a question commonly asked. A surgeon is entering um, into the abdomen. Which artery is most difficult to find? So they ask this again and again. Any idea? Yeah, post-ileal is pretty difficult. And which is the most common position? So this again is a common question asked. Post-ileal is pretty difficult. Pelvic is also pretty difficult. Which is the most common position? Retrocecal, yeah. Retrocecal is the most common position. So that is the one that's behind cecum. So they again ask, this again is a common question asked in anatomy. A surgeon enters the appendix, surgeon enters the abdomen, where do you say the surgeon to look for the appendix? So this again is a very common question asked. So you say them to look in the retrocecal first because that is the most common. And then the other questions are least common, doesn't matter. Most common is retrocecal. And then anatomy recall, blood supply we've already seen. That is a surgical anatomy. So as you can see, one identifying feature of the appendix, meeting point of three coli. Yes, correct. Meeting point of three coli. That is correct. Tinea coli. That will be the appendix. When you trace the tinea coli along the inferior, along the ascending colon, you're going to see the appendix. So that is an easy way to find out. But this again, they say look in the retrocecal position where you trace and it gets fused. Yeah. And then nerve supply. Nerve supply is from which the sympathetic, especially the sympathetic fibers. Sympathetic fibers is from which level? So this has again a referred pain. So this is why there is a classical referred pain to umbilicus. Yeah. So T10 is a major nerve supply for the appendix, and this is why you have a referred pain to umbilicus. Okay. So this covers up the basics of appendix. Even if you don't know, it's okay, but just make sure you know that. So an appendicular artery is an end artery. This is why it is easily susceptible to gangrene, a thrombosis, anything. It can gangrene can become gangrenous very easily. Okay, and then one more thing is lumen decreases as age increases, hence it can be easily obstructed. This is why appendicitis is more common. So, what is the common causes of appendicitis that you know? I know it's given, but what have you seen? They say specific things, right? For example, fecolith is very common. Fecolith obstruction. Yes, correct, Sanjana. Fecolith. This has been the most common. But let's assume it's in a case of a small young adult, like a child around 10 years, or let's assume it's a HIV positive individual, something like that. HIV positive individual, a child around 10 years, they expect this lymphoid proliferation. So this is also possible, lymphoid proliferation. So this lymphoid proliferation also can cause obstruction of appendix. Okay. So this also is given external mass. So this is known as it can be a carcinoid tumor, it can be any other external tumor, or it can be a thrombosis of appendicular artery. Whenever they're going to say whenever they're expecting you to choose thrombosis of appendicular artery, they're probably going to say a case of AF or atrial fibrillation. So a possible case of atrial fibrillation presents with right lower quadrant pain and then has classical symptoms, you're going to think appendicular artery thrombosis. But why? Because it has thrown a clot or an emboli. So this is why atrial fibrillation becomes a very common scenario here. In questions, theoretically, this is one of the common scenarios tested, especially for SMA thrombosis and appendicular artery thrombosis. So some common questions tested here, AFib, okay. And then, yeah, clinical features, everyone knows this. Right lower quadrant pain initially around the umbilicus, and then that spreads to the right lower quadrant. And this is McBurney's point. McBurney's point is dash. It's a line between umbilicus and dash. McBurney's point is 2/3, 1/3 is an in between line between ASIS. Yes. So this is going to be the ASIS. So this is your McBurney's point. What is McBurney's sign? What is McBurney's sign? Yes, so it's going to be tenderness at the McBurney's point. It's not pain at the McBurney's point. Yeah, it's not pain. So that is the main thing. This is what I was going to try because whenever people think McBurney's sign, they say it's pain at McBurney's point. It's not pain, it's a sign. So you're going to elicit the sign. So when you press, so it's a tenderness. It's not pain, it's tenderness. Okay. So it's tenderness at McBurney's point. That is McBurney's sign. Apart from that, a person with appendicitis will present with fever, nausea, vomiting. If it's in a pelvic position, you're going to have bladder irritation, maybe mimicking a picture of cystitis, but not actually cystitis. In the blood, it's going to show leukocytosis. I've covered this again, but yes, leukocytosis in the blood. So this is a classical picture of appendicitis. Okay. So these are some signs again, especially in uncomplicated appendicitis. You're going to see this. McBurney's sign, as I already said, is tenderness at McBurney's point. What is Bloomberg sign? What is Bloomberg sign? Just one word. That's all. Correct. Bhupinder has actually found it. It's rebound tenderness. Bloomberg sign is rebound tenderness. Yes. And then Rovsing sign, it's basically if you're going to press in left iliac fossa, you're going to get pain in the right iliac fossa. So that is Rovsing sign. So as sign, I already said retrocecal. When you do move this, when you do extend the leg, you're going to get, I mean, when you're going to flex the leg, you're going to get psoas sign. Operator sign, when you're going to extend it, rotate, you're going to get operator sign. So all of this, remember this. Psoas sign and operator sign are seen in retrocecal positions. This is the most important key because they give you a lot of questions them, and then they're going to say the patient shows psoas sign positive. What is the most common position? Retrocecal. Irrespective, it's retrocecal, but yeah, the psoas sign and operator sign specifically show a retrocecal position. So they are characteristic of retrocecal position. As I said, in a pelvic case, it can mix cystitis. Same way in a retrocecal position, psoas sign and operator sign are important. If you know these three, it's more than enough. These both are additional points. This is Rovsing sign. So what happens is there is going to be generalized peritonitis or inflammation. So when you press on the left iliac fossa, the fluid is going to shift to right iliac fossa. This is going to cause pain. So when you press on left iliac fossa, you're going to get pain in the right iliac fossa. So this is Rovsing sign. And then, okay, moving on, complicated appendicitis. A complicated appendicitis is a surgical emergency. Correct or wrong? A complicated appendicitis is a surgical emergency. By complicated, yeah, okay. So again, see, so people who actually said no, you're actually correct because a complicated appendicitis, it basically means it has perforated or it has formed an abscess or it has formed a mass. All these things you're not going to operate immediately. You're not going to operate immediately. Not operate, okay? You're going to do drainage. You're going to support. You're going to give antibiotics, okay? So, but the person with perforation will present with peritonitis. What are the cardinal features of acute abdomen? What are the cardinal features of acute abdomen? I'm going to give you tenderness. The other two are in the slide, but I want to, yes, it's guarding rigidity. Always remember, guarding rigidity. It is in the ascending order. Okay, so tenderness, guarding, rigidity. As it increases, more severe, more severe. Rigidity is the sign. You get rigidity, you can be sure it is acute abdomen. So it's a complicated case, perforation possible, peritonitis positive, you're going to get acute abdomen signs. Okay. It is an acute abdomen if there's immediate perforation. For example, the patient came in, he was just having a right lower quadrant pain. So a patient came in, he was just having a right lower quadrant pain. Now he developed the signs of acute abdomen. Then the appendix has perforated. In this case, it is an acute abdomen in the initial stages. You're going to look for bleeding. You're going to manage as if it's an acute abdomen. But surgery is a question mark. Okay. This is a case of acute abdomen where you're not going to do surgical intervention immediately. You're going to wait. Okay. Same way, a complicated appendicitis, for example, with abscess or an ileocecal mass, rather ileocecal mass, right iliac fossa mass, a right iliac fossa mass. You're going to wait. Okay. How to elicit guarding? See, guarding is one of the signs where they can voluntarily guard. When you're going to press, there will be a tense in the abdominal sign. So it's a clinical class, but you're going to flex. You're going to put the knees in the semi-flex position with the patient sleeping. When you do go to palpate, you can feel the tensing of the abdominal wall. This can be voluntarily also because see, you're going to touch. So the pain, the person knows when you touch, he's going to get pain. So he himself will tense the abdominal wall. This is known as voluntary guarding. But most of the time, it can also be a pathological guarding. So that is guarding. When you're going to palpate, there will be a tensing of the abdominal wall. Okay. So lab investigations, any case of acute abdomen, it's going to be the same thing. A, B, C, D, E followed by IV access fluids. Okay. So when you do send, you're going to obtain an IV access, you're going to send laboratory investigations. Okay. As always say CBC, RLE. And this is a surgical case. So you're going to send for PTANR, blood grouping cross matching, grouping typing and cross matching. So this is going to be same CBC, RLE, PTANR, blood grouping cross matching. Everything is going to same. This is this both, especially because it's a surgical case. So in the CBC, you're going to see a WBC elevation more than 10,000 for sure. Urine analysis. Why urine analysis? Why am I saying urine analysis for this patient, an appendicitis patient? Why do you need to do urine analysis? Okay, pus. So basically, I'm hoping you're thinking UTI can make it. Yeah, rule out UTI. That's all. You have to rule out UTI. So that is the main aim, rule out UTI. And then RLE, which is RFT, LFT electrolytes, and coagulation profile because it's a surgical case. And most important, this is again and again tested UPT or serum pregnancy test in females, especially reproductive age group. Reproductive age group presents with this, you're going to do a UPT. Let's assume the UPT is positive. What is the key differential? Right? Yes. Rather than just ectopic, severe case, it can be ectopic is the most, it can also be ruptured ectopic. So that is why it is or an impending rupture ectopic. So ectopic should always be a key differential for appendicitis in a female. Okay, never forget this. Whenever a female comes in, the question might be so big. It can be for 4 pages. If it's a female, the answer is UPT. Without UPT, don't proceed. So this is very important. And then imaging. See this again, this is not something that I've shown you so many CT scans, X-rays showing. I've asked you what is this, what is this. This is something that you're not going to diagnose. This is something a radiologist is going to diagnose because the two modalities they're going to use is USG and CT scan. Okay. Yeah, Ayush, it's correct. Meteorology, endometriosis, they're all differential diagnosis in appendicitis, but most importantly, ectopic. Ectopic is a key differential there. That is what you have to rule out first in the female. So imaging studies, female initial investigation is going to be for female is imaging studies USG. You're going to rule out again pregnancy and ectopic. Okay. And then if the appendix diameter is greater than 6 centimeter with wall thickness greater than 3 millimeter, just remember this has been asked more than once in exams. Appendix diameter greater than 6 centimeter. Then you say it as definitive appendicitis. Okay. Just remember this. So this is USG. USG is sensitive, but it's not that sensitive. Gold standard is going to be CT abdomen. So in CT abdomen, you're going to see periappendiceal fluid collection or periappendiceal abscess. You can see fat stranding. So these are three words that I just want you to remember. So obviously the appendix is going to be distended. And if there are perforation, the best method to find if there is a perforation is CT scan. Okay. These are just pictures I've added. You can even find fecal present or not. I don't want you to, like, they're never going to ask you see the USG or see the CT and diagnose. There's not one such case, but just remember greater than 6 centimeter appendix in USG, you're going to say appendicitis or you're going to suspect an appendiceal obstruction. Okay. Okay. So this is another scoring system. This is important. So this is why I put it here. Mantrel scoring system or Alvarado scoring system. So Alvarado scoring system is the actual name. Mantrel is the short form. So Mantrel is migration of pain, usually umbilicus to right iliac fossa, anorexia, nausea, tenderness in right lower quadrant, rebound pain, elevated temperature, leukocytosis, and left shift of white blood cells to the left. Okay. So all of this has been, this is known as Mantrel scoring system. There has been modifications. Some colleges still follow the previous, some follow the modification. Don't worry about it. Just remember tenderness in right lower quadrant and leukocytosis. These both carry 2 points. This is the key feature. So tenderness in right lower quadrant and leukocytosis carry 2 points. And then why am I saying Mantrel scoring? Because MANTRLS is the short form of it. So remember it as slide next to lab investigations. This one. Do you mean this one, Sarika? Okay. Okay. So is there any clarification or you just wanted to see it? So I can move on, right? Okay, I'm going to take that as an S and I'm going to, okay, I'm going to take that as S. So Alvarado scoring or Mantrel scoring. So Mantrel scoring, as I said, is a short form. Migration of pain, anorexia, nausea, temperature is tenderness, rebound pain, elevated temperature, leukocytosis, shift to white blood cells to the left. So in this tenderness and leukocytosis is carrying 2 points. So this is just going to say likelihood of appendicitis 1 to 4, 5 to 7, 8 to 10. Okay. The higher the scoring here, you're going to avoid conservative management. Okay. So this again is a blanket statement. you are seeing a case of acute appendicitis. Do you do surgery or not? It's a case of acute uncomplicated appendicitis. Do you do surgery or not? This is a question now. What is the last point? Shift of white blood cells to left. Okay, I'll tell you. I'll come back on. So I'll just answer my question now. So you have seen a case of acute appendicitis. Do you do surgery or not? It's a blanket statement. Just tell me yes or no. Ayush has answered yes. Anyone else who's saying no, yes, anything? Yes, okay, yes. Okay, so you're all answering yes. But now there is also one more possibility where someone will say there is a conservative management. So this conservative management is known as Ochsner-Sheren regimen. Okay, Ochsner-Sheren regimens usually preferred in cases where it can be a complicated appendicitis or it's an acute appendicitis with some other co-forms. For example, the patient won't survive under anesthesia, something like that. So then you go for Ochsner-Sheren regimen. Okay, a lump ileocecal mass is the and ilio and right iliac fossa mass is the reason why Ochsner-Sheren regimen was introduced. Right iliac fossa mass. So it can be an appendicular mass, it can be an ileocecal mass. If it's an acute case, you're going to do Ochsner-Sheren regimen. But I'll come back to it in just once again. So shift of white blood cells. Okay, this means you're going to have a left shift. Left shift is immature WBCs are going to be present a lot. So when you say immature WBCs, it means it's a left shift. It's a shift in the left side of the heritage cycle. So that is a left shift. Okay. So moving on, Ochsner-Sheren regimen. Ochsner-Sheren regimen, yes, it is a case of RAF mass. This has also been used in case of conservative management of appendicitis. So this appendicitis can be either complicated or uncomplicated. Whenever they say conservative management, yes, you do interval appendicectomy. Yeah. If you're going to do acute appendicitis with conservative management, any surgery, I'll come back to it. You just remind me in the end if I've not covered it. I do have a flow chart for this. If it's not covered in that, I'll make sure I answer your question, Ishan. So for now, so Ochsner regimen, RAF mass, right iliac fossa mass is the key, but conservative management has been done. So what is RAF mass? When can you do it? So no periappendicular fluid collection must be present. No abscess, no perforation. In these cases, patient is stable, non-toxic. You're going to do something known as waitful watching. Baseline investigations, NPO, Riles tube, IV antibiotics, TPR, BP, abdominal girth chart, IO chart. So these are supposed to be maintained. Temperature pulse rate BP is going to be maintained 1 hourly or 2 hourly. Abdominal girth half a day, so 12 hourly. And IO chart you're going to maintain. When you do maintain all of this, provided if there is an emergency or if the appendix ruptures, you'll be able to take them to surgery. Only then you're going to do Ochsner-Sheren regimen. Unless and until you're not going to have that facilities, you're not going to do Ochsner-Sheren regimen. If the patient is, you're going to do if patient recovers, you're going to do an interval appendicectomy. So this is one thing that I did. It was a case of a recurrent appendicitis. So the first time the patient had, she was too sick for surgery. The second time was when she was under my care. So she again was a 13-year-old girl who came here. She had appendicitis. This time, the reasons I know, recurrent appendicitis usually do surgery, but in this case, what happened was theater wasn't available, and the father wasn't there to make the decision. The mother didn't want to make the decision, so we had to opt for an Ochsner regimen. In this case, we did do waitful watching, and then she later came on for an interval appendicectomy. So this is something that is done, but provided you have the facilities for operation like emergency EOT, you say emergency OT or an ICU where you can manage all this, you can do Ochsner regimen successfully. But Ochsner regimen has been successfully implemented only in case of RAF mass till date. Rare cases of scenarios where for appendicitis you do Ochsner regimen. It has been done. Okay. And then again, operative management, you have laparoscopic open. There are multiple incisions for open surgeries. We usually prefer modified McBurney's incision. So this is usually done. Modified McBurney's incision is usually preferred. But apart from the laparoscopic, remember it's a 3-port laparoscopic technique. This is a question that they're going to ask you. What is the incision? How many ports are used in appendicitis? How many ports are used in cholecystitis? So these are two common questions that they ask. How many ports are used in appendicitis? How many ports are used in cholecystitis? So both they've asked. See, again, they don't know about senior resident. They ask how many ports. That's it. So it's either three or four in case of cholecystitis. Which is it? In case of appendicitis, yes, it's three. In case of cholecystitis, three or four. Yeah, correct. So cholecystitis 4, appendicitis 3. Kindly remember this. This again in NEET question or in USMLE, they're not going to ask like this. NEET or your professors, they're not going to say senior resident. He'll say if I operate, I'll operate in two port without even camera. He'll operate and go. That's because of his head weight. So that doesn't matter. Our point is 3 is for appendicitis, 4 is for cholecystitis. That is what happens. Okay. And then perforated appendix or appendicular abscess. So this is a case where it is a complicated appendix. It has become perforated. This is because there's been an abscess. So in this case, you're going to do non-operative management. You have nothing to remove that. The appendix has ruptured. Abscess has formed. There is nothing to remove for you. There is nothing there. If you enter now, it's going to be full of additions. Okay. As you remember, this is again an appendix case. An acute inflamed appendix is going to have additions around it. Can you tell me why? An acute appendix, let's assume it's a 16-year-old boy who has had no surgeries before. I should just be specific as to what regimen. Okay. You mean surgical regimen? Are you asking about surgery? Operative. Oshner-Schillen. Yeah, like I told you, right, in my hospital, we did follow Oshner-Schillen regimen. Yeah. In my hospital, we followed Oshner-Schillen regimen. There might be modifications in local protocol, but you do follow in some hospitals. If you have the facilities, you follow. And some rare cases, you do. Okay. So perforated abscess or appendicular abscess, there is nothing to operate. So you're going to prefer a non-operative management. It is ruptured. So what are you going to do? You're going to do IV fluids. You're going to put them on NPO, IV antibiotics, gram positive, gram negative, anaerobe coverage. So what will be an ideal antibiotic for perforated appendicitis? I've given you yesterday itself. What is an ideal antibiotic for perforated appendicitis? What can be? Not just metronidazole. I want the full, it's a cocktail. Metronidazole won't cover gram positive. It's going to be a cephalosporin plus a metro. So it's going to be zone, ceftriaxone plus metronidazole. Ceftriaxone plus metronidazole. And if wanted, amikacin is added. Okay. Nothing more than that. Yeah, piptaz if zone doesn't care, it's the same group. Okay. Piperacillin, tazobactam, zone is preferred. But yeah, zone, metronidazole, amikacin plus or minus. So, and then you're going to go for percutaneous drainage of abscess. So this is done. And then once the inflammation is resolved, following interval appendicectomy, 6 to 8 weeks. Okay, now I remember what question I was asking is, you open an acute appendicitis, there is going to be inflammation. Let's assume this is the appendix. There is going to be adhesions around it. Like the surgeon has not done, the patient has not undergone any other surgery. No surgeries at all. But still you're going to have adhesions around appendix. Why? This is a question. Why? Why is there additions around appendix? Acute inflammation. So what is going to come and add that? Usually we do have fibrosis bands because we are manipulating it. As you have all remembered omentum, yes, it is a great policeman. They say it's a great policeman. You will never know that till you open a case of appendicitis and see, you will not see the appendix. It will be buried under layers of omentum because omentum will come and surround it completely. So that is how it is. So it is a policeman because it's going to blanket the appendix. That is a criminal there, right? Because that is the one that's causing. Yeah, it is the one that's going to cause your appendicular mass. But that is why, if the inflammation has reached to a point, you're going to go for conservative. Even if you open, you're not going to find anything. That is the level of how the omentum can adhere. Okay. So if the clinical condition worsens, you might have to deal with a case of acute abdomen. Maybe let's assume the perforated abdomen is worsening, peritonitis is worsening. Then you are going to open him and see, explore if there is some other cause and not just the appendix first. So this is possible. Okay. So this is the algorithm. So an appendicitis is suspected clinically. Okay. So classical presentation, symptoms less than 48 hours, periumbilical pain migrating to McBurney's point, nausea, vomiting, anorexia, leukocytosis in WBC or leukocytosis in CBC. You're going to go for appendicectomy. Done. This is your simple, uncomplicated appendix. So uncomplicated. Why additions? Additions is because omentum is the great policeman. So the momentum is gonna try to contain the inflammation there. So it's gonna come surround the appendix, trying to contain the inflammation. So that is why adhesions are gonna be there around the appendix. You'll never be able to find the appendix if there is so much momentum. So this is the algorithm. I think Ishan, this will probably tell you as to why, but if not, I can tell you again. So appendicitis suspected clinically, supportive care. Classical presentation, everything is classical, you're going to do appendicectomy. Now let's assume it's an equivocal. You don't know if it's sure or not. An adult male, non-pregnant female, you're going to do CT. CT, if it's perforated or if there's phlegm that is abscess, you're going to give antibiotics. Okay. If it is perforated or phlegm that is necrosis or something like that, if there's an abscess formation, you're going to give antibiotics. Okay. Antibiotics heal. You wait for the patient to heal. You're going to do interval appendicectomy. If it is a case of non-perforated appendicitis, you're going to do appendicectomy. Okay. And then again, equivocal presentation, pregnant female or child, you're going to do USG rather than CT. Why? Because to reduce X-ray, that is radiation exposure, you're going to do this. You're going to prefer an USG. These are small things that I love this flowchart for this reason. So pregnant child, you can do MRI, but MRI takes time to book. So because MRI, you can't get it urgently. There is no something known as urgent MRI. At least where I work, there is nothing called as urgent MRI. You can't do it. You have to wait for 1 day or 2 days. So pregnant female or a child, not pregnant female child, a pregnant female or a child, USG is preferred. Perforated abscess, you're going to look for it. Percutaneous drainage, antibiotics, you're going to consider interval appendicectomy. Again, a pregnant female or a child, USG, no perforation, you're going to go for appendicitis, non-perforated appendicitis, go for appendicectomy. So this is your flow chart for management of appendicectomy in short. Okay. Now there are some special conditions. Negative appendicectomy. There's a question on it. I'll let you decipher then. I'll let you then later. Then there's an appendicitis in pregnancy. I'll finish this and I'll come back. There's a lot of, yeah. So appendicitis in pregnancy. So this is one of the most common causes of acute abdomen in a pregnancy. Where is the pain gonna be? In a pregnant female, where is the pain gonna be in appendicitis? It's gonna be in your right upper quadrant or right lumbar region. So it's gonna be mimicking a lot, okay? It's gonna mimic a lot of things. It can mimic, yeah, slightly. It's not just slightly above. There are cases where even lumbar pain, you find it's an appendicitis case. So that high up, it can be pushed up, okay? So it's very difficult to diagnose. Leukocytosis can also be physiological. Position is varied, but treatment is going to be appendicectomy. There is no difference in that, okay? Then pseudoappendicitis. What is pseudoappendicitis? What is the causative organism? Causative organism of pseudoappendicitis. Causative organism, Yersinia. Yes, we already covered it in one more class, I think. Yersinia. Yersinia is the uh, causative organism of pseudoappendicitis. It's going to mimic appendicitis, but it's in Yersinia. You give antibiotics, it's going to go. And then appendicular neoplasm, I'll cover it in a flow chart. In which trimester, in any trimester, you do appendicectomy. There is no specific conditions as to which trimester. If the patient presents with pain, you're going to do appendicectomy. You don't want a perforated appendix in the pregnant woman. You're going to do appendicectomy. You're going to explain the risks, especially in first trimester. There is a chance, but chance of miscarriage is very, very low in case of anesthesia in the first trimester or any trimester for the matter. And back to Sumaya's question, why don't we do appendicectomy directly for equivocal presentation? As I said, inflammation. There is going to be inflammation there. You're not going to see anything. That is the main reason. Okay. Do we prioritize appendicectomy over high-risk fetal loss? We prioritize mother's loss over high-risk fetal loss. If the mother is going to develop peritonitis, then mother is going to die soon. So think like that. Don't say appendicectomy over fetal loss. You're going to prioritize mother's health over fetal health. You yourself said it fetal, not child's. So it's a mother over fetus. Yeah. So this is going to deal with your appendicular neoplasm. So this again is a very important flowchart. These two flowcharts, I loved it very much when I was studying. It gives you almost every detail that you want, especially in neoplasm. It is usually lacking in many books. Even SRB, I don't think explains it to this, like covers it so much. So appendicular neoplasm can be two things. It can be a carcinoid tumor, or it can be an adenocarcinoma. When adenocarcinoma is present, it can form something known as pseudomyxoma peritonei. Okay, so it's gonna form mucinous adenocarcinoma, especially. So it's gonna form mucinous adenocarcinoma. This is gonna form pseudomyxoma peritonei. So you're gonna have mucinous deposition all over the peritoneum. It is possible. So this is known as pseudomyxoma peritonei. Okay, so it can be a carcinoid or an adenocarcinoma. Now, diagnosis of appendicular neoplasm is mostly intraoperative. You find an appendicular neoplasm intraoperative. I'm sorry, wait a second. Just give me 1 minute. From front, okay. So you find a intraoperative neoplasm. Let's assume the neoplasm is less than 2 centimeter, does not involve cecum. You're going to do appendicectomy only, nothing more. There are no invasive. Then this appendicectomy specimen is sent for histopathology. In the histopathology, no invasive features less than 1 centimeter or carcinoid 1 to 2 centimeter without suspicious lesion. You're going to keep the patient on surveillance. That's it. You're going to say, come for review, we'll get a CT scan done. So that is surveillance. So this is a simple factor. Now, let's assume a neoplasm greater than 2 centimeter or neoplasm involving cecum, or the HPE sent comes back as histopathology of adenocarcinoma, or a carcinoid to 1 to with suspicious histology. In these cases, you're going to go and proceed with a right colectomy. So it's a neoplasm to, you're opening the abdomen, you're seeing an appendix, there is a mass of greater than 2 centimeter. It's greater than 2 centimeter, irrespective of the position, you're going to do right colectomy. That's it. There is no point, I'm going to come back, wait for thing. No, you're going to do right colectomy. If the neoplasm involves cecum, that is, if the mass is near the base of appendix, then you're going to do right colectomy. Okay. Or you already went ahead, the mass was small, you saw the mass, it has come over adenocarcinoma, you're going to open again, you're going to do a right colectomy. So this is done. So this is another part. Now then finally, you open the abdomen, you're going to see peritoneal dissemination. The peritoneum is going to be rough. There is going to be seedings all over peritoneum. You're going to do biopsy of the specimen. You're going to do appendicectomy. You're going to do a staging workshop. So these are all stage procedures. You're going to look for the source. So CEA, CA 129, CA 125, CT chest, abdomen, pelvis, colonoscopy. You're going to do all of this. If there are no metastatic disease, you're going to do a cytoreductive surgery. Cytoreductive surgery is basically you're going to remove all the tumor mass and you're going to subject them to intraperitoneal chemotherapy. It's too much to learn all this. Remember when you're going to do appendicectomy, when you're going to do right colectomy, when you're going to further proceed. That's how I want you to remember. That's all. So we'll just summarize this whole thing into, again, just simplify it. Okay. You're opening abdomen, you're seeing a mass in appendix, mass in appendix. So first, neoplasm less than 2 centimeter, neoplasm involving cecum. Does not involve cecum. Does not involve cecum. What are you going to do? A neoplasm less than 2 centimeter does not involve cecum. You're going to do what? You're going to do only appendicectomy. Okay. You're going to send the specimen for histopathology. Histopathology is normal, surveillance. If histopathology is abnormal, you're going to do right colectomy. When else do you do right colectomy? You open the abdomen, you see a mass greater than 2 centimeter. The mass is involving the base of appendix or involving cecum. You're going to do a right colectomy. Next, you're going to see a mass, huge mass or peritoneal dissemination. Then you're going to go for staging workshop, staging laparotomy. Staging laparotomy, biopsy, metastatic workup. It's known as metastatic workup. And then you're going to proceed like that. Okay. So this is what I want you to remember. So this flowchart can further be simplified like this. I hope this is clear. This again is a very importantly tested topic. Appendicular neoplasm. What do you do, especially in incidental appendix? It's very important that you know this. So clinical scenarios. A 22-year-old female comes to the ER with complaints of severe epigastric pain in the right lower quadrant for the past 3 hours. There is tenderness on palpation in the right iliac fossa. Pulse rate is 102 beats per minute. BP is 100 by 60. What do you do next? What do you do next? They've already done ABCDE plus, right? No, no, no. I want you to think it's a female. Female, female, female. What did I say? Female. What is the first thing you do? Yeah, UPT. And Ishan, you came close. Okay, you do come close. Imagine USG. You're gonna do USG. Irrespective, you're gonna do USG. Okay. USG is going to be done. UPT is the first thing you do for a female that comes with right iliac fossa pain. So this was a key feature. Never forget this. 22-year-old female comes in with right lower quadrant pain. They will deny any previous history of sexual intercourse. They will deny marital extramarital contact. You still are going to do an UPT irrespective. That is a key thing. Okay. Especially in India, they're going to deny everything, but you're going to do an UPT irrespective. A 22-year-old male came to ER with complaints of severe pain right lower quadrant past 3 hours. There is tenderness and palpation in the right iliac fossa. Pulse rate is 122. BP is 90 by 50. By this time, whenever they give you vitals, they have done ABCDE. You have to recognize when not to tell ABCDE. So this is a scenario where you're not going to tell ABCD because they're giving you vitals usually. When they do give you vitals, they give you all this. It's a clinical scenario. ABCD is correct, but yes, okay. What do you do next? So in this case, what do you do next? I'm sorry, the CECTC was all for this question, USD. So again, Sumaya, you are correct. I'll tell you all you are correct, but the options are USD, appendicectomy, wait and watch. What do you do? The options are A, B, C. A, B, C. USD, appendicectomy, wait and watch. What do you do? Now this tricks you a bit, isn't it? It's a 22-year-old male, came with severe pain. Okay, Sumaya is saying USD, Rachel, USD, Khan. So C is not the option. I'm giving you why C is not the option. So everyone is stuck between B or A. I'm seeing a lot of A's. I'll tell you the answer was B. You know why? Because 90 by 50. There's a low BP. So patient is unstable. Take him to OR. Patient is unstable. Take him to OR. Remove the appendix. So this was the option they gave. It was USG was given. Appendicectomy is given. The same question they gave. It was a female. What do you do? BP is stable here. So you're going to do USG first. If the BP is unstable, let's assume 90-40, you're going to take them to OR first. You're going to do an UPT on meanwhile, you're going to take them to OR. Can be ureteric colic. Differential diagnosis for appendicectomy involves males, females together. Ureteric colic, you're going to have an RAF mass. It can be any peritoneal rupture, it can be an ileocecal TB. There are so many differential diagnoses. It can be an ureteric colic, but severe abdominal pain, tenderness in right iliac fossa. Ureteric colic with tenderness is very rare. Tenderness is a clinching feature. As I said, ureteric colic is it's just because of contraction of the ureter. Just because you press ureter is not going to contract a lot. Okay. Here, contraction of ureter is not going to cause pain just because apply. So tenderness means shift more towards appendicitis in the question. I know ureteric colic will give you a confusion, but shift more towards appendicitis because they say tenderness. Okay. And then again, I know we don't read vitals, but 90 by 650 is apparently unstable, and you do appendicectomy here. Okay. Moving on, a 30-year-old woman, 24 weeks pregnant and presents with 5-hour history of abdominal pain. On examination, she has point tenderness on the right iliac fossa. Pelvic examination is normal. Her laboratory is unremarkable for WBC. Unremarkable is remarkable. Okay, is remarkable for WBC of 14. What is the next best diagnostic step? So they have given you your next best diagnostic step. This itself is going to clue you in. So what is the next best diagnostic step you're going to do? Yep, it's going to be USG. So you're not going to do CT scan for this patient because she's pregnant. You're going to do USG. Now, the patient described above. She has undergoes appendicectomy, diagnostic workup, and an acute non-perforated appendicitis is diagnosed. It has been diagnosed as acute non-perforated appendicitis. All of the following are a part of management of acute appendicitis in pregnant women except prophylactic therapy prior to further treatment options to protect the fetus, intravenous antibiotics, urgent laparoscopic appendicectomy, urgent open appendicectomy. So what is what is the answer? A, B, C, D. Okay. I'm not sure if the answer is going to be same, but please remember the word except is there. The word except is there. And I think Ayush. I don't know how to give the cheer, but yeah, Ayush, he actually answered it correct. You're not going to give tocolysis. The patient is 24 weeks pregnant. Tocolysis is stopping uterine contraction. This doesn't make sense at all. Tocolysis is not going to be done. You can do either open. So this question I put it for two reasons. First, look out for accept. Second, open or laparoscopic, both are accepted in appendicectomy. In pregnant female, you can do both open and laparoscopic. The open is preferred more than laparoscopic. Okay, both can be done. Intravenous antibiotics is a must. There is a word except here. So all these three are correct. There is no role of tocolysis. Tocolysis is done when the uterus is contracting. Right now, uterus is not contracting. Tocolysis. Toco is contraction, lysis is break. Contraction break. That's not going to be done here. So tocolytic therapy is not going to be useful, and tocolysis does not protect the fetus as well. So yeah, that was a tricky question. Moving on. You are consulted by the emergency department to evaluate a 19-year-old man with acute abdominal pain. The patient reports the pain started around his umbilicus around approximately 12 hours ago and is now more severe in the right lower quadrant. You have high suspicion of acute appendicitis and you elect to take this patient to open operating room for laparoscopic appendicectomy. Foregoing diagnostic imaging. Upon entry into abdomen, you know the appendix is grossly normal. However, the cecum and ileum are severely inflamed. Abdomen otherwise looks normal. What is the most appropriate next step? A. Continue with appendicectomy and refer the patient to gastroenterologist. B. Leave the appendix, close the abdomen, refer the patient to gastroenterologist. C. Resect cecum, appendix, and terminal ileum end block. D. Biopsy an area of inflammation, send for frozen section to determine the best surgical option. And then E. Biopsy an area of inflammation for pathology and close the abdomen. Okay. So I'll just give you one reason as to why you're all wrong. This question was taken from USMLE question. Okay. This is an USMLE question. Now everyone change your answer to the correct one. This is a USMLE question, okay? I'll give you the answer now. All of you are thinking in the terms of a Indian doctors to what we do here. I know I'm not supposed to speak bad of this, but what is the correct answer now? This is an USMLE question where patient rights are respected. Okay. Yeah. So everyone again is sitting between. It's the answer is B. B is the answer. Leave the appendix, close the abdomen, refer the patient to gastroenterologist. So this is why patient care in India, it hasn't reached the point. But remember this: the appendix is normal. You came here for nothing. Close the abdomen and go. Just because the cecum is inflamed, if you're going to take a biopsy, how do you actually take a cecal biopsy? Any idea as to how do you take a cecal biopsy? Let's assume it's a rectal biopsy, cecal biopsy. How do you take? What procedure do you do? Do you open the abdomen? How do you take a cecal biopsy? Inflamed appendix, inflamed cecum, inflamed. So how do you take a cecal biopsy? So what method? What is the key method? Let's assume a 60-year-old man comes in with anemia. 60-year-old man comes with anemia. What is the first investigation you're going to do? It's not endoscopic. Change the first four letters. It's not endo. It's not endo. How do you call it? A 60-year-old man comes in with anemia. Not procto. Procto is very, very, very low. Neoplasia, yes. What is the first investigation you're going to do? First investigation for and colonoscopy. Aditi is correct. You're going to do colonoscopy. So that's how you take a biopsy. You say inflamed cecum, you're going to put a colonoscopy, endoscope, camera up his rectum. You're going to see the colon and biopsy which area is inflamed. You're not going to do a per abdominal biopsy. So that is where this both comes wrong. If you're going to see a mass, you're going to do a per abdominal biopsy. This is not a mass. You're not seeing a mass. You're just seeing inflammation. It can just be a case of ulcerative colitis. It can just be a case of Crohn's. You will not know unless until you take a biopsy. The biopsy is taken via colonoscopy and not per abdomen. Kindly remember this. Then, a 45-year-old man presents to the emergency department with right lower quadrant pain, fever, nausea. And one more thing, just in case. This is known as a negative appendicectomy. Okay. Negative appendicectomy. The key feature about negative appendicectomy, nothing is wrong. You're going to close and come back. You're not going to do something known as prophylactic appendicectomy. Prophylactic appendicectomy is not done. It is not supposed to be done in case of suspect. You're opening incidentally Prophylactic appendicectomy is not done incidentally. Just remember this. This is a very key feature. Don't do this ever. Don't choose continue with appendicectomy and come back. Never choose A, okay? And then a 45-year-old man presents to emergency department, right lower quadrant pain, fever, nausea, anorexia. Given high clinical incidence of appendicitis, patient is taken immediately to the operating room for laparoscopic appendicectomy. On entry into the abdomen, the appendix is noted to appear normal, except for a 3 centimeter mass at its tip. What is the next best step? Continue with laparoscopic appendicectomy only. Perform colectomy. Perform right colectomy with removal of at least 30 centimeter of terminal ileum. Close and refer to medical oncology for neoadjuvant therapy. Close and perform CT scan for surveillance. Okay, so Ayush has answered A. Any other answers? So it's a 3 centimeter mass at tip. 3 centimeter mass at tip. Do you want me to go back to the slide where I've given the flow chart? It is a neoplasm greater than 2 centimeter. It's a neoplasm greater than 2 centimeter or a neoplasm involving base for both. So if it is a neoplasm greater than 2 centimeter or a neoplasm involving the base, you're going to do right colectomy. Yeah, it can be a simple cost, right? But you're not going to take a risk. So that is the thing. So that is why D is correct. Because if it's an adenocarcinoma, it becomes an invasive procedure to again put the patient through general anesthesia. So you rather would do a laparoscopic appendicectomy, you rather do a right colectomy. But yeah, this again is a very theoretical question. Person will go for a frozen section biopsy and so on and so forth. But the theory is you have to do a right colectomy. So this brings us to the end of the class. Thank you for attending. So kindly fill out the feedback forms that is going to be shared. Tomorrow is again my class, 14, that is tomorrow, 6 p.m. There's a topic on hemorrhage, okay? We'll be dealing about hemorrhage and what are the aspects of blood transfusion and all that. We'll be reading about blood transfusion and all that. So this is one of the flow charts. And this is the other flow chart. And do fill out the feedback form. It helps me a lot.
Recording
okay?
stopped.
Thank you, Dr. Kaushik, for such an insightful session. I'm sure we all learned a lot. Please do fill out the feedback form in the Zoom chat to receive a certificate of participation. Please note that certificates of participation and recording are provided to MSN members only. If you attend a minimum of 15 workshops from our Clinical Acumen series, you will receive a letter of recommendation from MSN highlighting your consistent efforts to improve your clinical knowledge and skills. A link has been shared in the chat box with all events and CV building opportunities offered by MSN. Follow our Instagram handles for regular updates. I will leave the meeting on for another 5 minutes so everyone can access the feedback form in the chat.